Magnesium is the second most abundant cation in the body and is required for muscle relaxation after contraction and for more than 300 biochemical reactions in the body. Approximately 50 to 65% of total body magnesium is found in the bone, with the remainder found in intracellular fluid, with the exception of 1% in the extracellular fluid or intravascular system. Because magnesium is stored primarily in the bones, measuring the blood level of magnesium is not adequate to establish the total amount of available magnesium. The primary source of magnesium is through the diet. The recommended daily intake is 320 to 420 milligrams per day. Magnesium is plentiful in leafy green vegetables, grains, nuts, dried foods, legumes, dairy products, meats, and seafood. It is absorbed in the ileum and excreted in stool and urine. The kidneys act as the main regulator of serum magnesium concentration. It should be noted that urine magnesium levels reflect hypomagnesemia before serum levels do. Serum magnesium deficiency can result in low calcium, potassium, and phosphate in the blood. Magnesium performs the functions listed on this slide. Magnesium deficit manifestations are similar to those of hypocalcemia and hypokalemia because magnesium, calcium, and potassium are all cations. Hypomagnesemia can cause the heart muscle to spasm and the heart to stop beating if there's not enough magnesium to relax the heart between contractions. Chronic alcoholism is the most common cause of hypomagnesemia. Hypermagnesemia, or magnesium excess, is relatively rare but a potentially lethal electrolyte abnormality. It is found primarily in patients with renal impairment because normal kidneys are able to eliminate excess magnesium. Hypermagnesemia is usually asymptomatic. Magnesium supplementation is the most frequent cause of magnesium excess. Magnesium imbalances may be caused by actual or relative increases or decreases in magnesium. An actual increase or decrease occurs as a direct result of magnesium gain or loss. A relative increase or decrease occurs when magnesium shifts back and forth between the intercellular and extracellular compartments. A relative increase in magnesium may also occur when the blood is concentrated secondary to fluid volume deficit. Actual hypomagnesemia may be caused by direct loss, inadequate intake, impaired absorption, or increased excretion of magnesium, resulting in actual decrease in serum magnesium. Diarrhea, draining intestinal fistulas, ileostomy, and prolonged gastric suctioning result in direct loss of magnesium ions from the body. Excessive diaphoresis also results in direct magnesium loss from the body. Chronic lack of magnesium may be due to a diet low in fruits and vegetables. Only about 50% of dietary magnesium is absorbed. Starvation and eating disorders such as anorexia and bulimia may lead to inadequate magnesium intake. Decreased absorption of magnesium may be caused by gastrointestinal disorders such as inflammatory bowel disease, Crohn's disease, and chronic pancreatitis. Magnesium absorption is also decreased when vitamin D and parathyroid hormone levels are low, similar to calcium. Certain medications, such as aminoglycoside antibiotics, antifungals, and protein pump inhibitors may interfere with magnesium absorption in some individuals. Alcohol dependency is a common cause of hypomagnesemia. Alcohol acts as a magnesium diuretic, causing an increase in the urinary excretion of magnesium as well as other electrolytes. Chronic intake of alcohol causes the body stores of magnesium to become depleted. Diuretics such as Lasix cause increased renal excretion of water, sodium, potassium, and magnesium. Loop and thiazide diuretics cause an increase in phosphate excretion as they act on the kidneys to increase urinary output. Relative hypomagnesemia may occur when magnesium shifts into the intracellular compartment. Excessive intake of water causes magnesium concentration in the blood to become dilute. Excessive administration of IV solutions without magnesium supplementation may cause serum magnesium levels to become diluted, resulting in hypomagnesemia. Hypokalemia is common in patients with hypomagnesemia, occurring in 40 to 60% of cases. Actual hypermagnesemia by excessive magnesium intake, increased absorption of magnesium, magnesium retention, or inabilities of the kidneys to excrete magnesium results in an actual increase in serum magnesium. Hypermagnesemia usually results from a combination of excessive magnesium intake and impaired renal function. Oral ingestion of magnesium-containing antacids, vitamins, and Lasix are the usual culprits. Therapeutically induced hypermagnesemia may occur by administering excessive IV magnesium, which is used to treat severe asthma, to correct some lethal dysrhythmias, and to prevent seizure activity in pregnant women with eclampsia. Anesthesia decreases bowel motility, allowing excess magnesium to be absorbed in the intestines. Chronic constipation, bowel obstruction, and paralytic ileus also cause a decrease in bowel motility. Certain medications, such as narcotics, increase magnesium levels by inducing bowel hypomotility. Acute renal failure and chronic kidney disease render the kidneys unable to excrete magnesium adequately. The most common cause of hypermagnesemia is renal failure. Hypothyroidism is associated with elevated magnesium and calcium levels. Hypoparathyroidism may be caused by low serum magnesium levels. Magnesium is required for parathyroid hormone secretion. The nurse should conduct a focused nursing assessment for magnesium imbalance, beginning with a thorough nursing history. Interview the patient and family members to identify any risk factors or pre-existing conditions that would contribute to magnesium imbalance, such as vomiting, nasogastric suctioning, diarrhea, acute kidney injury, chronic kidney disease, or other conditions associated with magnesium loss or gain. The nurse should also assess the patient's ability to drink and tolerate oral fluids. Include a current dietary history, inquiring about dietary habits. The nursing history should include lifestyle factors such as long-standing alcohol use and chronic malnutrition, current medications, including excessive antacid or use of glucocorticoids or chemotherapeutic agents. A thorough physical assessment is necessary. Specifically, the patient should be asked about muscle cramps. Assess each body system, observing for manifestation of magnesium imbalances as well as related calcium imbalances. Measure and record the patient's vital signs and review laboratory data to assess for the presence of hypo or hypermagnesemia. Monitor for cardiovascular changes. Auscultate the patient's apical pulse. Monitor electrocardiogram changes. Check orthostatic blood pressures. Monitor for neurological changes. Establish patient's usual cognitive and behavioral pattern. Observe the patient's behavior, level of consciousness, and mental status. Monitor for seizure activity. Monitor for gastrointestinal changes. Auscultate bowel sounds in all four quadrants. Observe the frequency and consistency of bowel movements. Monitor for neuromuscular changes. Establish a baseline for the patient's deep tendon reflexes, muscle strength, and muscle tone. Monitor the patient's serum magnesium levels. Remember that hypocalcemia and hypokalemia usually accompany hypomagnesemia. Also monitor renal function blood studies. Those would be your BUN and creatinine. For asymptomatic hypomagnesemia, administer oral supplements as ordered to a patient who can tolerate oral medications. Magnesium hydroxide, or Phillips milk of magnesia, Maalox, about 10 milliliters 1 to 2 times per day. Magnesium oxide, 400 to 800 milligrams 3 times a day. Magnesium chloride, better known as slow mag, may be used. It causes fewer diarrhea stools, but also delivers less magnesium. Oral magnesium supplements may cause diarrhea. This side effect can be reduced by dividing the daily doses into 2 or more doses. Treatment for severe hypomagnesemia includes the administration of IV magnesium sulfate. IV magnesium sulfate is used to treat severe hypomagnesemia if the patient is experiencing neurological changes or cardiac dysrhythmias. Magnesium IV should be administered very slowly, 1 to 4 grams magnesium in normal saline. The rate should not exceed 1 gram per hour. Generally, 1 gram per 100 milliliters of IV fluid is the concentration. Monitor blood pressure, pulse, respiratory rate, and electrocardiogram frequently throughout the administration. Excuse me. Respirations should be at least 16 breaths per minute before each dose. Monitor neurological status and implement seizure precautions. Monitor intake and output to ensure adequate renal clearance. Assess deep tendon reflexes before each dose. Magnesium should be held and the healthcare provider notified if the deep tendon reflexes become more hypoactive or absent. Magnesium replacement must be given with extreme caution to a patient with renal impairment, renal function because of increased risk of hypermagnesemia. Decreased dosing and more frequent laboratory monitoring and clinical monitoring are indicated in a patient with any degree of renal impairment. The treatment for mild to moderate hypermagnesemia is to discontinue medications or preparations that contain magnesium, such as antacids, laxatives, or slow mag. Treatment of severe hypermagnesemia is done in an acute care facility with cardiac monitoring capabilities. Decreasing serum magnesium by direct removal, especially if renal failure is the cause, is done by hemodialysis. Administer IV calcium gluconate to treat the cardiac muscle effects of hypermagnesemia. Loop diuretics, such as Lasix, decrease serum magnesium by increasing excretion by the kidneys. Monitor cardiac function to identify and treat dysrhythmias. Continuous telemetry monitoring is essential to identify and treat potentially fatal dysrhythmias, especially if the patient is receiving IV calcium replacement. Reduce the environmental stimuli for a patient with hypomagnesemia. Provide a quiet room. Limit the patient's visitors. Darken the patient's room. Speak in soft tones. Implement seizure precautions for a patient with hypomagnesemia. Pad side rails. Have oxygen and suction equipment available. Ensure the patency of IV access devices. Administer emergency medications as ordered. Prepare for possible endotracheal intubation. Prepare for cardiac defibrillation if necessary. Implement fall precautions related to muscle weakness caused by hypomagnesemia or hypermagnesemia. Perform a fall assessment. Maintain bed in a low position with locked wheels. Remove all obstacles from pathways, especially to the toilet. Monitor for safety hazards such as torn carpet or liquid spills on floors. Place assistive devices within reach. Use nightlights. Instruct patient to ask for assistance to ambulate. Ensure availability of call light. Assess the patient's footwear. Provide anti-skid socks. Keep items such as telephone and fluids within reach. Request that the family members remain with patient if necessary. Position the patient to allow close observation by staff members. Communicate the patient's fall risk during the shift report. Teach the patient or caregiver the causes of magnesium deficit. Teach the patient how to identify the manifestations of magnesium deficit. Instruct the patient and family to notify the healthcare provider if the patient exhibits manifestations of hypomagnesemia or if they have any other specific concerns. Teach the patient how to prevent magnesium deficiency by consuming foods high in magnesium. Teach the patient how to take oral magnesium supplements. Magnesium supplements should be taken with meals. Taking them on an empty stomach may cause diarrhea. Instruct a patient who is also taking an iron supplement to take magnesium and iron supplements at least 2 to 3 hours apart. Teach a patient who is taking an extended release form of magnesium to swallow the tablets whole. Do not chew or suck on them. Ask the healthcare provider whether the tablets can be broken or crushed and sprinkled on applesauce or another soft food. Teach a patient who is taking the powder form of magnesium to pour the powder into a glass, add water, and stir well. Instruct the patient to report adverse effects such as nausea, vomiting, diarrhea, and abdominal cramping to the healthcare provider. Encourage the patient to keep appointments for laboratory studies to evaluate serum magnesium levels. Ensure the patient or caregiver understands the specifics, rationale, potential side effects, and desired effects of treatment regime. Include medication administration, nutrition, hydration, dietary restrictions, and foods high in magnesium. Teach the patient or caregiver the causes of magnesium excess. Teach the patient how to identify manifestations of magnesium excess. Instruct the patient and family to notify the healthcare provider if the patient exhibits any manifestations of hypermagnesemia or if they have any other specific concerns. Teach the patient how to prevent magnesium excess. Advise the patient to avoid high magnesium foods. Teach the patient and caregiver how to read labels that list the amount of magnesium in each serving. Ensure that the patient or caregiver understands the specifics, rationale, potential side effects, and desired effects of the treatment regime. Include medication administration, nutrition, hydration, dietary restrictions, and foods high in magnesium in patient teaching. This slide represents some listings of foods that are high in magnesium. Document all assessment findings and interventions per facility policy. Evaluate and document the patient's response to interventions and education. Serum magnesium levels should return to normal. Other lab values should return to normal. Vital signs should return to baseline. Underlying cause of magnesium imbalance should be resolved. Level of consciousness should return to baseline.